Welcome back. In this video, we will focus on the cutting edge, most up-to-date guideline about heart failure management. Truly, we will explore 2022 American College of Cardiology, American Heart Association guideline to find out the key updates for our heart failure management. And I believe this lecture will be helpful not only for those who are preparing for exams. It could be your board preparation, your usmle exam or clerk exam. It will be also helpful for all those physician colleagues, APP colleagues who are taking care of multiple heart failure patients, both in inpatient and in outpatient. So let's start. My name is Dr. Farzana Hoque. I'm an associate professor of medicine. So now I will share this slide and together we will find out what are those key takeaways for heart failure management. And if you are new to this channel, I truly appreciate your presence and please like this video, share with your friend and please subscribe to this channel because that motivates me to make more educational videos for you. So let's jump in. So as I mentioned, we will focus on 2022 American Heart Association, American College of Cardiology, HFSA guideline for management of heart failure. This is a huge guideline. So we will focus on what are the new and important updates relevant to our knowledge and clinical practice. So let's first focus on stages of heart failure. First stage is stage A, or at risk of heart failure. Patient is at risk of heart failure, but there is no current signs symptoms, such as patient with history of cardiovascular disease, high blood pressure, diabetes, obesity. Second stage is stage B, or pre-heart failure. Patient does not have any current sign or symptoms of heart failure. However, patient may have one of the following, such as increased BNP, increased troponin, increased filling pressure, or a structural heart disease. Then the next stage is stage C, or symptomatic heart failure. Patients with current or previous signs symptoms of heart failure. And finally is stage D, which is advanced heart failure. Patient has marked heart failure symptoms that is impacting the daily life, having recurrent hospitalization, despite optimal guideline-directed medical therapy or GDMT. So as you know, mostly we focus on stage C, or symptomatic heart failure. So let's explore what is the trajectory of stage C heart failure. It could be new onset or just newly diagnosed heart failure, resolution of symptoms, and here guideline use using the language, the terminology from oncology, such as heart failure in remission. Thirdly, it could be persistent. Patient has ongoing signs, symptoms. And lastly, worsening heart failure or functional capacity. We know that, okay, heart failure is a clinical diagnosis. We must need history, physical exam. For diagnosis, we know that we will need NT, pro-BNP or BNP, and maybe sometimes transthoracic echo or additional testing if needed. After the heart failure has been diagnosed, we need to determine, okay, what could be the cause or precipitating factor. We need to initiate treatment and also, importantly, serial heart failure assessment. This is crucial for this current guideline because, previously we talked about, okay, we have to diagnose, we have to treat, but need to emphasize that, okay, after diagnosis, after treatment, we must have to have serial heart failure assessment so that we can optimize the medication. Now let's focus on classification of heart failure according to ejection fraction. The first one we know, heart failure with reduced ejection fraction or half RAF, that is EF less than or equal to 40%. Second is heart failure with mildly reduced EF, which is EF 41 to 49%. Thirdly, heart failure with preserved EF or half PAF, that is EF more than or equal to 50%. And lastly, heart failure with improved ejection fraction, meaning that patient at baseline had EF less than or equal to 40%. And now there is more than or equal to 10-point increase from baseline EF, and current EF is more than 40%. This is a new addition to this current guideline, and that is important because when we treat our heart failure patients, a significant number of patients, we truly want their EF to be improved. So I truly like that, okay, now this current guideline is having a specific classification for those patient population as well. Let's focus on heart failure with reduced EF less than 40% treatment. We use diuresis for decongestion, and worth to notice that current guideline is telling quadruple therapy or 4 essential pillars of heart failure with reduced EF are ARNI or ACE inhibitor or ARB, secondly beta blocker, thirdly mineralocorticoid receptor antagonist, and fourthly SGLT2 inhibitors. Those are the 4 essential pillars of treatment of heart failure. And definitely the next stage is optimizing the medical therapy. What about heart failure with mildly reduced ejection fraction, that is EF 41 to 49%? We need diuretics as needed to ensure decongestion. Here, I would like to draw your attention that SGLT2 inhibitor has now 2A indication for heart failure with mildly reduced ejection fraction. In addition, ACE inhibitor, ARB, ARNI, MRA, and beta blocker has 2B classification. 2B indication for heart failure with mildly reduced ejection fraction. We know that, okay, beta blocker, we are using beta blocker for heart failure for long. We must have to remember that one of these 3 beta blocker should be used for heart failure patients, that is bisoprolol, carvedilol, or metoprolol succinate. Sometimes I see, even in the US and multiple other countries, when I review patients' chart, that, okay, they are on other beta blockers such as atenolol. Those are not guideline-directed medical therapy for beta blocker. Either any of these 3 should be induced for heart failure patients for beta blockers because it reduces mortality, morbidity, and also hospitalization. So beta blocker is critically important for our heart failure patients. Key points on beta blocker that it need to be titrated over weeks until the patient achieve the guideline-directed targeted dose or maximum tolerable doses. There is always the question, okay, should we use ivermectin? Need to emphasize that patient must be on maximally tolerated beta blocker therapy before starting ivermectin. Now let's focus on the next pillar of quadruple therapy, that is angiotensin receptor neprilysin inhibitors or ARNI. BNP is falsely elevated in patient treated with ARNI. So we have to measure NT-proBNP. What to notice that there is no increased risk of hyperkalemia with ARNI compared to ACE inhibitor or ARB. There is no increase in risk of elevated creatinine compared to ACE inhibitor or ARB. However, there is more hypotension with ARNI compared to ACE inhibitor because we know that there are 2 vasodilators in ARNI. which is sacubitril and valsartan. Question is, does sacubitril or neprilysin inhibitor work alone? The answer is no. Because, as you can see, when neprilysin inhibitors are used alone, it can increase adverse remodeling. It can also increase angioedema. So, neprilysin inhibitor does not work alone, and that's the reason why valsartan is added in ARNI. And I believe this is important particularly for our listener who are preparing for any board exams or any licensing exams. Let's know a couple of clinical parts for ARNI. ARNI reduce mortality and morbidity. And very important to practice and remember that the patient who are already tolerating ACE inhibitor or ARB, current guideline emphasize to replace by the ARNI because it further reduce mortality and morbidity. So if your patient is already tolerating ACE inhibitor or ARB, guideline is emphasizing to change it to sacubitril valsartan or ARNI to further reduce mortality and morbidity. Critically important to remember that ARNI must not be administered within 36 hours of last dose of ACE inhibitor. To make our patient's life easy, I usually tell them, 2 days, 48 hours, because that is also my peace of mind that, okay, there is no, co-administration of ACE inhibitor with ARNI. And ARNI must not be used for patients who has history of angioedema. It is contraindicated for those patients. Now let's focus on the next pillar of quadruple therapy, that is mineralocorticoid receptor antagonist. For heart failure with reduced ejection fraction patient with New York Heart Association class 2 to class 4, mineralocorticoid receptor antagonists such as spironolactone or eplerenone is recommended to reduce mortality and morbidity. However, as physicians, we must have to carefully monitor the potassium and renal function when patients are on mineralocorticoid receptor antagonist or spironolactone or eplerenone. If they are on diuretics, please be extra vigilant to focus and to monitor their potassium and creatinine. Guideline is very clear that, okay, if the patient is not able to maintain potassium level less than 5.5, mineralocorticoid receptor antagonist should be discontinued to avoid life-threatening hyperkalemia. The last one is sodium glucose cotransporter 2 SGLT2 inhibitors. Patient, irrespective either they have diabetes or not, if the patient has heart failure with reduced ejection fraction, SGLT2 inhibitor is recommended to reduce hospitalization and mortality. So if you have a patient who has heart failure with reduced ejection fraction and patient does not have diabetes, that patient is also should be on SGLT2 inhibitors according to 2022 ACC-AHSA guideline. We must not prescribe SGLT2 inhibitors for our type 1 diabetic patients because of increased risk of diabetic ketoacidosis. What about diuretics? Diuretics is recommended to relieve congestion, to improve symptoms, and also to prevent worsening of heart failure. If the patient is congested, you can also add thiazides such as metolazone along with loop diuretics if they do not respond to moderate or high dose of loop diuretics. There is always a question that, okay, should I give torsemide, furosemide? Which one is better? Fortunately, now we have data that was published in the Journal of American Medical Association, or JAMA, recently, and their focus was to find out the effect of torsemide or furosemide after discharge on all-cause mortality in patients hospitalized with heart failure. And the bottom line of this study is that among patients discharged after hospitalization for heart failure, torsemide compared with furosemide did not result in a significant difference in all-cause mortality over 12 months. Now let's focus on a couple of additional medical therapies after optimizing guideline-directed medical therapy. One is ivabradine. Ivabradine can be used for patients whose ejection fraction is less than or equal to 35% with New York Heart Association class 2 to class 3. Important to remember that they should be on normal sinus rhythm. Their heart rate should be more than 70 at rest, and they must be on maximally tolerated beta blockers therapy. One of the side effects of ivabradine is arrhythmia, such as atrial fibrillation. So for clinicians, it is extremely important to make sure that our patients has normal sinus rhythm before adding ivabradine, because otherwise ivabradine can trigger the worsening of arrhythmia such as atrial fibrillation. The another one is digoxin. This is one of the commonly used drug, particularly in some of the developing countries. So digoxin can be used for symptomatic heart failure patients who continue to have symptoms despite guideline-directed medical therapy, or unable to tolerate medical therapy, or truly unable to afford guideline-directed medical therapy. It does not reduce mortality or morbidity. However, it reduces hospitalization for heart failure. Now let's focus on heart failure with preserved ejection fraction, or HFpEF, EF more than or equal to 50%. Notably, there is an increased incidence of heart failure with preserved EF lately, particularly from 2011 to 2014, there is high rise of HFpEF. When we are treating HFpEF, we can use diuretics as needed, and there is a 2A indication for SGLT2 inhibitors, and ARNI, MRA, ARB has 2B indications. I would like to draw your attention here. Notice that there is no beta blocker mentioned in the treatment chart for heart failure with preserved ejection fraction, because the patient who have HFpEF, they have fixed stroke volume and they are so much dependent on heart rate. So they should not be on beta blocker, just like, for all of them, unless they have other clear indication for beta blocker, such as atrial fibrillation. So use beta blocker carefully for all of your patients who have heart failure with preserved ejection fraction. In 2023, American College of Cardiology has published expert consensus on heart failure with preserved ejection fraction. So let's see what are the important parts we need to remember for our clinical practice and exam from this expert consensus report. First and foremost, when we are treating heart failure with preserved ejection fraction, managing the comorbidities is crucial, and truly it should be our first priority. So what are the main comorbidities of HFpEF, such as high blood pressure, obesity, diabetes, atrial fibrillation, and sleep apnea? For all patients with HFpEF, preserved ejection fraction with heart failure must be on SGLT2 inhibitors according to the current guideline. Natriuretic peptide are lower in obese individuals with HFpEF. We know that BNP could be lower for obese patients. Notably, the patients who have HFpEF and obese, their BNP could be much lower. So we need to be careful when we are diagnosing all these patients just only based on BNP. Women with heart failure with preserved ejection fraction have more dyspnea with worse health status. So we have talked about the quadruple therapy or 4 essential pillars of guideline-directed medical therapy. The key question for us is that truly can we save lives by the GDMT? The answer is yes, we save lives. And fortunately, we have data that was published in the Lancet. And this study, observed that, okay, how GDMT is reducing the mortality. And as you can see that this study found out that there was 8 additional years free from the cardiovascular death or heart failure hospitalization, along with 6 additional years of overall survival when patients were on guideline-directed medical therapy. So we must have to continue the guideline-directed medical therapy to ensure that, okay, we are reducing the mortality and morbidity for our heart failure patients. However, heart failure, when a pregnant patient has heart failure, need to be vigilant that all those GDMT like S inhibitor, ARB, ARNI, MRA, SGLT2 inhibitors must not be administered. Truly, they are contraindicated because of significant risk of fetal harm. So whenever a patient with heart failure get pregnant, we must have to discontinue all these medications if she is on these medications. What are the other medications we need to be cautious? First, if the patient has heart failure with reduced ejection fraction, they should not be on non-dihydropyridine calcium channel blocker, such as verapamil diltiazem. Also, NSAIDs, because NSAIDs can worsen the symptom and it should be avoided or withdrawn whenever possible. Thiazolidinedione, we know that, okay, it increases volume overload. So if the patient has heart failure with reduced ejection fraction, thiazolidinedione should be discontinued because it can worsen heart failure symptoms and can cause hospitalization. Additionally, DPP-4 inhibitors such as saxagliptin, alogliptin must be discontinued whenever the patient has heart failure because DPP-4 inhibitors can increase the risk of heart failure hospitalization and must be avoided for heart failure patients. One of the questions truly commonly asked by the patients to us that, okay, now I'm feeling fine, my echo is better. Should I stop all of my medications? The answer is patient must be continue all the guideline-directed medical therapy to prevent relapse of heart failure and left ventricular dysfunction. Importantly, even if patient become completely asymptomatic. And we have evidence about it. There was a study done that was published in Lancet in 2019. And as you can see that, okay, when compared to the control group, when the patient was withdrawn from the GDMT, their remission of heart failure was significantly higher. So how often should we titrate guideline-directed medical therapy? 2022 SCCH guideline recommend to titrate it every 1 to 2 weeks, but definitely depending upon your patient's symptoms, vital signs, other lab findings such as potassium and creatinine. Whenever our patients are coming to hospital, we need to make sure that, okay, we are identifying the precipitating factor, understanding the severity of congestion, along with optimizing the volume status. And if the patient is not on GDMT, it is our responsibility as clinicians to start GDMT or optimize the GDMT, because there is a study has been done. It's shown that okay, if we initiate any medication in the hospital setting, the adherence is much higher compared to initiate that medication in outpatient setting. The GDMT during hospitalization, it should be initiated as soon as there is clinical stability. And for any reason, if it is discontinued, it should be reinitiated and further optimized during the hospitalization. Because I believe that is important for all the physicians and APP colleagues, because sometimes there is a hesitancy that, okay, should we start or optimize GDMT during the hospitalization? And I'm glad that now guideline is supporting us and giving us the evidence that, okay, it is reasonable to start and optimize the GDMT during the hospitalization, particularly after clinical stability. Follow-up after discharge for heart failure patients is critical, and guideline is now very clear to emphasizing the 7-day of hospital discharge follow-up after the discharge from the hospital to optimize the care and to reduce the hospitalization. We know that there could be a lot of barriers for GDMT implementation, like sometimes patient could have physiologic limitation, other comorbidities, or financial challenges. It could be from the hospital or healthcare system. Truly, heart failure management is much more than guideline-directed medical therapy. It's not only just telling the patient, okay, take your medications. It's truly much more than that. And it should be patient-centered care where physician and patient should be team. And as clinician, it is truly our responsibility to review our patient's medication list to make sure that, okay, there is no polypharmacy, because polypharmacy is quite prevalent. And for our heart failure patients, sometimes they could be just adding, so many medications without, and they could be seeing multiple physicians. So there is chance of polypharmacy is very high. So we need to make sure that, okay, how we can optimize their medication, not only just putting them at the risk of polypharmacy. Addressing comorbidities for heart failure management is critical. And it's surprising to know that nearly 50% of symptomatic heart failure patients has iron deficiency anemia. And sleep disordered breathing can be found nearly 60% of heart failure with reduced ejection fraction patients. For iron deficiency, guideline is emphasizing that, okay, if the patient has heart failure with reduced ejection fraction and iron deficiency with or without anemia, IV iron replacement is reasonable to improve the functional status and quality of life. What to notice that it is not recommended to give erythropoietin stimulating agents for heart failure with anemia patients. What about high blood pressure or hypertension? We should optimize our GDMT to make sure that, okay, patient is blood pressure in the target range. Sleep disordered breathing is quite prevalent. So sleep study is necessary if you feel that, okay, patient could be having obstructive or central sleep apnea, and giving them the, CPAP if the patient needed, if the patient meet the criteria for obstructive sleep apnea. For diabetes, if the patient has heart failure and type 2 diabetes, SGLT2 inhibitors is recommended for management of hyperglycemia as well as to reduce mortality and morbidity. Management of atrial fibrillation in heart failure patient is essential. If the patient has atrial fibrillation and CHA2DS2-VASc score, if they're meeting the criteria for anticoagulation, patient should be on chronic anticoagulation. And regarding chronic anticoagulation, DOAC is recommended much over than warfarin for eligible patients. And we know that the Chadwick score need to be equal to or more than 2 for men, or 3 or more than 3 for women for the chronic anticoagulation therapy. For ages, we have told our patients that, okay, be cautious about fluid, not more than 2 liters. The question is, do we have evidence about it? There was a recent study done, and it was a meta-analysis of 6 randomized controlled trial comparing the liberal and restricted fluid intake. And they found that there was no difference in mortality and heart failure or hospitalization, no difference in serum sodium level or creatinine between the liberal and restricted fluid intake. So guideline is very upfront about it, that truly we do not have, adequate evidence to recommend that, okay, it should be liberal or it should be restricted. I truly like that part, that it is now acknowledging that the evidence about it is uncertain. So truly it should be shared decision making between you and your patient, depending upon your patient's situation, to find out that, okay, what will be the ideal fluid regimen for your patient. What about salt? Similarly, fluid, for ages, we are telling our patients avoid salts. But question is, how much evidence do we have about it? There was a recent study that was done in Lancet, and the bottom line of this study is that low sodium diet was not associated with a reduction in adverse cardiovascular events. However, it was associated with modest improvement in quality of life. So the guideline is recommending that if the patient has a stage C or symptomatic heart failure, avoiding excessive sodium intake is reasonable to reduce congestive symptoms. I would like to end this talk with top 5 key takeaways. First of all, quadruple therapy, ARNI or ACE inhibitor ARB, MRA, beta blocker, and SGLT2 inhibitor are recommended for heart failure with reduced ejection fraction patients. Secondly, SGLT2 inhibitor can be beneficial to decrease mortality and heart failure hospitalization. Thirdly, treating comorbidity that can worsen heart failure, such as hypertension, sleep disorder, anemia, diabetes, is truly essential. Initiation and titration of quadruple therapy for heart failure in reduced ejection fraction is urgent, and we need to be vigilant that, okay, if the patient is in hospitalized or in outpatient, how we can make sure that, okay, we are optimizing that GDMT for our patients. And finally, in patients who have now improved ejection fraction after treatment, according to the current guideline, we should be continuing the guideline-directed medical therapy to prevent the relapse of heart failure. I hope you found value in this talk, and I truly appreciate your participation and presence in this talk, and I look forward to seeing you in the next video. Please make sure you are liking this video, you are sharing this video with your friends and colleagues, so that they can be also benefited from this important key message of heart failure management. I will see you in the next video. Until then, take care and stay well.